Place your hand on your chest right now. Feel that? That steady rhythm you never think about. The one that has been running without a single break since before you were born. Most people take it completely for granted, until the day they shouldn't. Here is what nobody tells you at your annual checkup. A heart attack almost never comes without warning. In over 85% of cases, the body sends clear, measurable signals days, sometimes weeks before the event. The problem is not that these signals are subtle. The problem is that they look like something else entirely. Fatigue, indigestion, a pulled muscle, a bad night's sleep. And by the time the connection is made, it is often too late to make it. I have been practicing internal medicine for 15 years. I have sat across from patients who described their warning signs to me in retrospect, after the event. Almost every single time, the signals were there. Nobody recognized them. A heart attack is not a sudden malfunction. It is the final stage of a process that began months or years earlier, and that process leaves tracks. Today, I am going to show you exactly what those tracks look like. I'm Dr. Arthur Sterling. Subscribe right now and hit like, because what I'm about to tell you, your doctor will not cover in a standard appointment. To understand the warning signs, you need to understand what actually happens inside your coronary arteries in the weeks before an attack. Your heart is supplied by 3 major coronary arteries. Think of them as highways delivering oxygen-rich blood directly to the heart muscle. When those highways narrow, due to plaque buildup, inflammation, or arterial spasm, the heart muscle begins receiving less oxygen than it needs. This process is called myocardial ischemia. Myocardial means relating to the heart muscle. Ischemia means insufficient blood supply. When the heart muscle is ischemic, oxygen-starved, it begins sending distress signals through the nervous system. Those signals do not always feel like chest pain. They radiate. They disguise themselves. They show up in places you would never connect to your heart. This is why the warning signs are missed, not because they are invisible, but because they speak in a language most people have never been taught to read. Here is the critical number. According to data from the American Heart Association, approximately 800,000 Americans suffer a heart attack every year. Of those, roughly 1 in 5 is a silent heart attack, meaning the person did not recognize the event was happening at all. They felt something. They explained it away. Days later, a routine EKG told the real story. Understanding ischemia, how it builds, how it signals, and how it escalates, is the difference between catching this process early and discovering it after the damage is done. The heart muscle is one of the only tissues in the human body that cannot regenerate after significant damage. Brain cells, liver cells, even bone all have some capacity for repair. Cardiac muscle, once destroyed by a heart attack, is replaced by scar tissue. That scar tissue does not contract, it does not pump. It is permanent. This is why the warning signs matter so much. You cannot undo what the attack destroys. You can only prevent the attack from happening. Let's go through each warning sign. I want you to be honest with yourself as we go through this list, because the most dangerous response to what I'm about to say is, "That happens to me, but it's probably nothing." Warning 1. Jaw, neck, or left shoulder pain with no obvious cause. The heart and the jaw share nerve pathways through the vagus nerve and the cervical plexus. When the heart muscle is ischemic, pain signals travel up these shared pathways and surface in unexpected locations: the jaw, the neck, the left shoulder, occasionally the upper back between the shoulder blades. Patients describe it as a dull ache, a heaviness, a persistent tension that does not respond to massage or position change. The key distinguishing feature: It comes and goes without a clear mechanical trigger. You did not sleep on it wrong. You did not strain it lifting something. It simply appears, often during mild exertion or stress, and disappears at rest. That pattern is cardiac until proven otherwise. Warning 2. Unexplained fatigue that is different from normal tiredness. When the heart is working harder than it should to push blood through narrowed arteries, it draws energy from the body's reserves at an accelerated rate. The result is a fatigue that does not respond to sleep. Patients describe waking up after 8 hours and feeling as exhausted as when they went to bed. Simple tasks, climbing a flight of stairs, carrying groceries, produce a disproportionate tiredness that was not present 6 months ago. This warning is particularly significant in women, where it is frequently the primary and sometimes the only symptom before a cardiac event. If your energy baseline has shifted downward over the past few weeks or months and you cannot explain why, that shift deserves investigation. Warning 3. Shortness of breath during activities that never caused it before. The heart and the lungs work as a unit. When cardiac output drops, when the heart is pumping less efficiently, fluid can begin to back up into the pulmonary circulation, the blood vessels of the lungs. This is called pulmonary congestion, and it makes breathing harder. You climb one flight of stairs and need a moment at the top. You walk to the mailbox and feel slightly winded. 6 months ago, you did not notice those activities at all. The distinguishing factor is the change. Not that you get winded, but that you get winded doing things that previously required no effort. That change in baseline is the signal. Warning 4. Pressure, squeezing, or fullness in the chest that comes and goes. Classic angina, the medical term for chest pain caused by reduced blood flow to the heart, is often described not as sharp pain, but as pressure, a heaviness, a sensation of something sitting on the chest. It typically appears during exertion and disappears within minutes of rest. Many patients dismiss it as indigestion, acid reflux, or muscle tension. Here is the clinical distinction. Indigestion responds to antacids and is usually related to meals. Cardiac chest pressure appears with physical or emotional exertion and resolves with rest. If you have been taking antacids for chest discomfort that actually seems to be triggered by activity, pay attention to that pattern. Warning 5. Sudden cold sweats, nausea, or lightheadedness with no obvious cause. When the heart is under severe ischemic stress, the autonomic nervous system, the system that controls involuntary functions like sweating, heart rate, and digestion, responds with a cascade of symptoms. Cold sweats that appear suddenly without fever or physical exertion, nausea that comes out of nowhere, a feeling of lightheadedness or impending doom that patients often describe as unlike anything they have felt before. This combination, cold sweat plus nausea plus chest discomfort or jaw pain, is a medical emergency. Call emergency services immediately. Do not drive yourself. Do not wait to see if it passes. Every minute of delay during an active cardiac event costs heart muscle that will not come back. Let me tell you about a patient I will call George, 57 years old, retired firefighter. The kind of man who had never missed a day of work in his life and considered going to the doctor a sign of weakness. George came to see me not because of his heart, he came because his wife made the appointment. She had noticed something he had been explaining away for 3 weeks. He sat down across from me, and I asked him to walk me through his last month. He said he had been more tired than usual, but he had been working on the house, so that made sense. He had noticed some jaw tension, but he had been grinding his teeth at night, so that made sense too. And twice in the past week, he had felt a strange heaviness in his chest while climbing the stairs to the 2nd floor, but it passed in a minute, so he figured it was just heartburn. 3 symptoms, 3 explanations. Every explanation was reasonable. Every explanation was wrong. What George was describing was a textbook prodromal presentation, the clinical term for the warning phase before a cardiac event. Prodromal means preceding the main disease. His coronary artery was narrowing. His heart muscle was sending distress signals through every pathway it had available. And George had been answering each signal with a logical alternative explanation. I sent George for an immediate stress echocardiogram, an ultrasound of the heart performed during physical exertion to reveal areas of reduced blood flow. The result showed significant ischemia in the territory of the left anterior descending artery, the vessel cardiologists call the widowmaker, because of what happens when it fully occludes. George underwent a stent procedure 4 days later. A stent is a small mesh tube inserted into a narrowed artery to hold it open and restore blood flow. His cardiologist told him afterward, if he had waited another 2 to 3 weeks, we would likely be having a very different conversation. George's wife noticed what George had been explaining away. She was right. He was wrong. And the 3 weeks he spent rationalizing those symptoms were the 3 weeks that nearly cost him everything. His jaw, his fatigue, his stares. His heart had been speaking for 3 weeks. He just needed someone to translate. Now, I want to address something directly. Some of you watching this are thinking, I don't have risk factors. I'm not overweight. I don't smoke. My cholesterol is fine. I need you to hear this clearly. Half of all heart attack patients have normal cholesterol levels at the time of their event. Cholesterol is one risk factor, not the whole story. The complete picture includes chronic low-grade inflammation measured by C-reactive protein, insulin resistance, which affects roughly 40% of adults over 50 and often produces no symptoms, sleep apnea, which stresses the cardiovascular system overnight, and chronic psychological stress, which elevates cortisol and directly damages arterial walls over time. You can have a normal BMI, normal cholesterol, and normal blood pressure, and still have significant coronary artery disease quietly progressing. This is why symptoms matter more than numbers. Your body's signals are more current than your last blood test. The single most underused diagnostic tool in cardiology is the coronary calcium score. It is a low-dose CT scan that takes less than 10 minutes and measures the amount of calcified plaque in your coronary arteries. A score of 0 means no detectable plaque, very low near-term risk. A score above 400 means significant disease requiring aggressive management. It is not part of a standard checkup. You have to ask for it specifically. It costs between $100 and $200 in most US facilities and is one of the most accurate predictors of cardiac events available. After 50, the risk profile changes sharply. Estrogen, which provides cardiovascular protection in women, drops significantly after menopause. Testosterone decline in men affects vascular elasticity. Arterial stiffness increases. The same level of plaque that caused no symptoms at 45 can trigger an event at 58. Age does not cause heart attacks, but age removes the margin for error that was quietly protecting you. Your doctor has 7 minutes. In those 7 minutes, they are checking your blood pressure, reviewing your medications, addressing the specific complaint that brought you in. There is no time and no financial structure that supports sitting with you and saying, let me teach you how your heart signals distress before it fails. The cardiology system in this country is extraordinarily good at treating heart attacks. It is structurally poor at preventing them. A stent procedure generates revenue. A conversation about jaw pain as a cardiac warning sign does not. That is not the cardiologist's fault. That is the architecture of a system built around intervention, not prevention. This is why this channel exists. Here is what you can do starting today. 4 things. No prescription required. 1. Know your numbers beyond cholesterol. Ask your doctor for a CRP test, C-reactive protein, which measures inflammation in your arterial walls. Ask for a fasting insulin level, not just fasting glucose. Insulin resistance precedes diabetes by years and directly damages coronary arteries. And ask about a coronary calcium score if you are over 50 and have any risk factors. 2. Take the stair test seriously. Walk up 2 flights of stairs at a normal pace. If you arrive at the top significantly more winded than you were a year ago, not slightly, but noticeably, that change deserves a cardiac evaluation. Not next month, this month. 3. Learn the difference between your normal and your not normal. Most warning signs are changes from baseline, not dramatic new events. The jaw tension that appeared 3 weeks ago, the fatigue that does not respond to sleep, the stares that feel different. These are changes. Changes are data. Start paying attention to your baseline. 4. If you experience chest pressure, jaw pain, cold sweats, and nausea simultaneously, especially during exertion, call emergency services immediately. Do not rationalize. Do not wait. The window for intervention during an active cardiac event is measured in minutes. Everything I described today, ischemia, prodromal symptoms, silent attacks, all of it becomes more likely after 50. Not inevitable, more likely. The margin your body had at 35 has narrowed. The signals it sends deserve more attention, not less. How old are you? Write it in the comments right now. I want to know who is watching, because the conversation about cardiac risk at 52 is different from the conversation at 67. And I want to make sure what I cover next speaks directly to where you are. Here is your action plan. 1. Place your hand on your chest and honestly review the past month. Unexplained jaw or shoulder tension? Fatigue that sleep does not fix? Stares that feel harder? Chest pressure that comes and goes? Write it down. 2. At your next blood draw, ask specifically for CRP and fasting insulin, not just the standard panel. 3. If you are over 50 with any risk factors, ask your doctor about a coronary calcium score. 4. Take the stair test this week. 2 flights, normal pace, honest assessment. 5. Share this video with someone you care about. The warning signs I described today are not rare. They are sitting in the daily experience of millions of people who have been taught to explain them away. Your heart has been working for you without a single day off since before you took your first breath. It deserves 5 minutes of your attention today. I'm Dr. Arthur Sterling. I've spent 15 years watching patients arrive after the event, wishing they had paid attention before it. Subscribe, hit like, and if this reached you, send it to someone whose chest you want to keep beating. The healthcare system profits from treating what goes wrong. I profit from making sure it doesn't.